So I'll come to hypoglycemia towards the end, the third case. So we'll start with the other two cases, which are more like a mini cases. Okay, so here is a patient, 55-year-old man, presented several years ago with weakness, reduced appetite. He was not eating well, and he had lost significant amount of weight in the previous 6 months. He had history of pulmonary TB 12 years previously, and he had completed treatment at that time, and has an occasional alcohol intake. So he was 73 kgs like 6 months previous to this consultation. The other vitals were fine, and this is what we found on physical examination. As you can see, there is hyperpigmentation of the tongue and the oral mucosa, and also the palmar creases, nails, right? Hyperpigmentation, blackish discoloration of the oral mucosa, as well as the skin and the creases, palmar creases, right? So many of you must have already probably guessed the diagnosis, but let us go ahead. The sodium was normal, potassium was elevated, 5.8. Cortisol was interestingly very low, 2.02. Ultrasound abdomen showed fatty liver, nothing else. Okay, so what was interesting and keeping with our suspicion was a low cortisol level. Normally, we expect a cortisol level to be more than 5 in the morning. No. Whenever you check a cortisol level, please check it in the morning, because that is when the cortisol is highest. And if it is very low at that time, that means it's abnormal. Okay, between 6 to 8 a.m. in the morning, you should get it done. Okay, so it's quite low. Cortisol level is quite low. So whenever cortisol level is low, sometimes all the clinical features goes with your diagnosis. You can directly diagnose Addison's disease, but it's always a good practice whenever we have the investigations available to confirm it with this test, ACTH stimulation test or a short synactin test, right? So this test is quite easy. It can be done in the ward, in any medical ward. You should draw a baseline cortisol, okay, and then give injection synactin, which is like the trade name or the company name is actin prolongatum. And nowadays they got another trade name, or a what can I say? It is Syntropac, SYNTROPAC. So this I've seen endocrinology residents keeping the ampules or the vials in their pocket during in the hospital rounds. So you give 250 micrograms of this IV. It is nothing but a high concentration of ACTH, what you call synactin. In Europe, they call it synactin test. In US, they call it cosintropin test. They're all the same. It is just a ACTH stimulation test. This is nothing but ACTH. You're trying to stimulate the adrenal cortex to see whether they are responding to the high concentration or the high levels of ACTH which you have in that injection. Right? Normally, I assume that you know a little bit of background of Addison's disease. See, adrenal insufficiency can be because of primary problem in the adrenal, meaning that there is less cortisol secretion in the adrenal gland. Not only cortisol, but other mineralocorticoids and androgens. That is, the primary problem can be in the adrenal gland. That is a primary adrenal insufficiency, or most common, Addison's is the most common form. Then you can have secondary adrenal insufficiency, where the problem is in the pituitary. So less ACTH is secreted, so less cortisol is secreted, right? So that is the secondary form. And tertiary form is iatrogenic. You must know a lot. I mean, I'm sure you come across a lot of patients who, for whom steroids are being abused. And also not only those patients, for some patients, they need it. For example, patients with rheumatoid arthritis or asthma, they are on large doses of steroids. And sometimes they're abused by some RMPs. They keep giving steroids, and the patient gets hooked on to steroids. So those patients, they develop Cushing's syndrome kind of faces, and they develop Cushing's syndrome. And suddenly you stop giving steroids to them. What happens? When you're giving steroids to patient, like iatrogenic steroids to patients, everything gets suppressed. ACTH, cortisol, everything gets suppressed. Okay, because you're giving free steroids. No, the body doesn't have to produce any cortisol on its own because you're giving it daily in the form of tablet. So when ACTH and cortisol are suppressed because you're giving steroids from external steroids, suddenly you stop giving the steroids, for example. Okay, then what happens? Then the body doesn't have the time to recover this axis, the hypothalamus pituitary adrenal axis doesn't have the time to recover. So there is no steroid in the body. Okay, and then they go into what we call as adrenal shock, right? So that is a tertiary form. So the primary form is when the adrenal gland is not producing enough cortisol. Okay, secondary form is when there's some pituitary problem, they're not secreting ACTH, so there is no cortisol. And the most common is tertiary or the iatrogenic steroids when the patient takes daily iatrogenic steroids. Okay, so this test is going to confirm adrenal insufficiency, whether it is there or not, and some clues to whether it is primary or not, primary adrenal insufficiency or secondary or tertiary. Okay, initial clue you already got it. See, the cortisol 2.02 is very low. So already you got some indication that the patient probably has adrenal insufficiency. Now this is just to confirm it. So when you're giving ACTH, injection of ACTH, what do you expect the normal adrenal gland to do? To secrete cortisol, right? So you're giving large amounts of ACTH in injection form, then the adrenal normally, if it's working normally, it should produce a lot of cortisol, high amounts of cortisol. So if it is not producing cortisol after giving the injection, that means that the adrenal gland is abnormal, it's diseased, it's not producing, it's not capable of producing cortisol. So that is the primary adrenal insufficiency. Okay. So you give the injection, after you check again after 30 minutes and again after 60 minutes, right? So now sometimes you don't have to do the 30-minute one. You can directly go for the 60-minute cortisol level. So in our patient, cortisol level after 60 minutes was only 1.7. You normally expect the cortisol to go up, right? In our patient, it went down. So definitely, so now it's 100% confirmed that the patient has adrenal insufficiency. Regarding the time, it doesn't have to be morning 8 a.m. Just an example, I've written 8, 8:30, 9 o'clock. It doesn't have to be like that. You can do it any time of the day. But if you're checking only cortisol, please check it in the morning. It's a screening test. Morning cortisol is a screening test, and this is like a confirmatory test to diagnose adrenal insufficiency. Okay. So this is what happens. So normal is the red line. Okay, normal is the red line, and so normal adrenal gland will respond to this injection, and the level will go up. That means there is no adrenal insufficiency for the patient with the red line. Whereas if you a patient whom you are giving from external, you are giving some steroids, adrenal is suppressed. Remember, long chronic steroid use can suppress the pituitary and adrenal gland. That HPA pituitary adrenal gland axis is suppressed. So there is not much of a response. A patient who has non-functioning adrenal gland, that meaning that is lost capability of producing cortisol entirely. In those patients, there is no elevation of cortisol at all. See the green line. So even after 1 hour, there is no response to the ACTH. So the green line is what we call as a primary adrenal insufficiency, and the commonest form of primary adrenal insufficiency is the Addison's. Okay, Addison's disease is nothing but an autoimmune disease affecting the adrenal gland. Okay. This is a flow chart. So first you do a morning cortisol. If more than 15, no adrenal insufficiency. I would take it as 5 rather than 3. So if it is less than 5, very likely to be ACTH stimulation. And if it's 5 to 15, it means it is, you need to confirm it. So after giving ACTH in the ACTH stimulation test, if it goes up to more than 18, that means you have ruled out adrenal insufficiency. Whereas if it doesn't go up at all, then there is adrenal insufficiency. Okay. Suppose this pink box is the adrenal insufficiency cases, right? Among adrenal insufficiency cases, if ACTH is elevated, it is primary, meaning Addison's. Whereas if ACTH is normal or low, it means secondary or tertiary. Okay. I hope it was not too complicated. Remember, there's always a feedback inhibition, feedback stimulations. That's what happens. If the adrenal glands are destroyed for some reason, there is ACTH, feedback stimulation of ACTH. So that's the reason why they're getting hyperpigmentation. Remember, there was some hyperpigmentation. Why? Because there is excess ACTH. And remember, MSH, melanocyte stimulating hormone, is a part of ACTH. So the melanocytes are kind of stimulated, causing hyperpigmentation. So in primary adrenal insufficiency or Addison's disease, we have hyperpigmentation. Why? Because of elevated ACTH. Okay. You don't see that in every case of adrenal insufficiency, only in primary adrenal insufficiency or Addison's. Right? So in our patient, he has what? He has Addison's. Why? Because he has hyperpigmentation. There was no response to ACTH stimulation test, and the ACTH level was very high. Okay, so he was diagnosed as primary adrenal insufficiency, started on long-term steroid replacement, and Hisone is like a trade name for hydrocortisone, right? So this is the usual regimen we give in people who have adrenal insufficiency: 10 mg in the morning, 10 mg in the afternoon, and 5 mg in the night. Okay, and when we saw him again after a few months, he had improved appetite, weight, and reduced weakness. So remember, this patient is not capable of synthesizing, producing cortisol on his own. So he's dependent on the medication that you're giving him. So for some reason, he forgets to take the medication. Okay. Then what happens? Then he'll go into adrenal shock. That is an emergency. At that time, he comes to emergency room. You have to give him IV fluids and also injection hydrocortisone for those patients. So that's why any patient who comes to your emergency with shock, with hypotension, please, it will take a little bit of history. Find out whether the patient is taking steroids and why did he stop taking steroids. So if he was taking steroids before and for some reason he comes with shock or hypotension, he needs a stress dose steroid, meaning 100 mg of hydrocortisone stat. Okay. A second. Let me just turn off my right. So he needs a stress dose steroid, 100 mg of person who comes with adrenal shock or hypotension, right? So our patient, and another thing, remember, like in the Western countries, for example, in US and UK and European countries, they have a steroid bracelet. So that suppose a patient just collapses somewhere in the street or in the park or somewhere, and the paramedics catch him. So they know that the patient is on long-term steroids and they can give him hydrocortisone right away. Not only people who stop taking hydrocortisone, even those patients who have vomiting and diarrhea. So in those patients also, they cannot absorb the steroid, oral steroid, and those patients can also become hypotensive. So those patients also, you need to start parenteral steroids. So please spend some time counseling the patient, tell him that the patient needs it long-term for the rest of his life. He cannot live without the steroid tablets. Okay. And if he has any surgery or if he goes into sepsis, he will need stress dose steroids. Okay. And he needs to be on a regular follow-up. He just cannot take the medication for some time and stop it. Right. Okay. So that was the first case. Second case, this is also a short case. Part of this is made up and part of it is real. The lab reports and everything else which I give you, which I show you are real. So 28-year-old woman who presents with weight loss, anxiety, palpitations. On examination, she has fine tremor and has a small diffuse goiter. Okay. And okay, so she's tachycardic with a heart rate of 120 per minute, and she also has an irregular pulse. So this is a classic case. I'm sure all of you must have already guessed the diagnosis. So she has what we call hyperthyroidism, excessive thyroxine secretion from the thyroid gland. Okay, so so just like adrenal gland, here also we have different kinds of hyperthyroidism, right? Is a problem a temporary problem, or is it more like what are the various kinds of hyperthyroidism you know of? So one which everyone remembers is Graves' disease, isn't it? Graves' disease is an autoimmune disorder where very commonly you have exophthalmos, protruding eyeballs, right? They also have pre-DPL mixed edema, right? So, but there are other forms of hyperthyroidism, okay? And one of the common ones is what we call as subacute thyroiditis or decurrence thyroiditis, where these patients need to have high clinical suspicion, because these patients will just come with vague symptoms, weakness, some pain in the neck or in the jaw, and they may also have low-grade fevers, okay, and weakness. So remember, hyperthyroidism can also be a differential diagnosis for pyrexia of unknown origin, okay? So whenever a patient complains of pain in the neck, very non-specific symptoms, weakness, tiredness, tachycardia, non-specific low-grade fevers, you will suspect thyroiditis, and you will check thyroid function tests, right? So that is what happens in thyroiditis. Because of inflammation, the thyroid follicles, they get destroyed, and the colloid is released into the systemic circulation, which contains the hormones. So all the thyroid hormones are get into the, whatever was stored in the thyroid gland gets thrown into the circulation. So the patient develops hyperthyroidism. And most of these cases, hyperthyroidism is temporary. After a few weeks or months, once all the hormone gets used up and that inflammation subsides, some of them become euthyroid, some of them become hypothyroid, some of them remain hyperthyroid. So you can't say for sure how it will eventually turn out to be. So that's why you have to monitor them. So thyroiditis, please, every patient with hyperthyroidism, don't take for granted that it is Graves' disease. Also, please keep in mind, thyroiditis is also one of the differential diagnosis. And other rare causes are hot nodule, hyperfunctioning nodule, one nodule in the thyroid gland which is secreting excessive thyroid hormones, or the multitoxic multinodular goiter is another rare cause. So there you go. In primary hyperthyroidism, the problem is in the thyroid gland, right? So you have high T3 and T4, and because of feedback inhibition, we have low TSH. It's a classic presentation of hyperthyroidism. You don't have to do free T3, free T4 every time, but in some situations where protein level is abnormal, or in a patient who is pregnant, it's better to do free T3, free T4. Okay. So, and also remember, for a patient with hypothyroidism, TSH alone is enough most of the times. For a patient with hyperthyroidism, you have to monitor TSH as well as the T3, T4, at least T4. What is this? This is the thyroid uptake scan. So how do you confirm whether it's Graves' disease or thyroiditis or something else? Probably we'll do an ultrasound of the thyroid to see for any nodules or anything like that. And wherever available, if we have all the investigations available, you can do TRAB antibodies, which I'm told is a little expensive. So in our place, they don't do TRAB. TRAB is thyroid receptor antibodies, which is elevated in Graves' disease because it is an autoimmune disease, right? But it's not available so easily, and even if it's available, it's expensive. So we do a technetium thyroid uptake scan, which is a nuclear medicine scan. This scan, of course, if it's a pregnant patient, you don't want to do this radiation scan. For those patients, somehow we'll do the TRAB antibodies. And if both are available, you can do both, but it's not required most of the times. So it depends on what kind of investigation is available at your place. So here you can see that there is increased uptake of the radioisotope by the thyroid gland. Okay. Right? There is increased uptake. This is how the thyroid uptake scan report comes, right? And what happens in other forms of hyperthyroidism? This is what you see in Graves, but what about others? Okay, this is what you see in others. So this one is Graves. There is increased uptake. Toxic multinodular goiter, it's irregular. Cold nodule, this is hot nodule, where it's a hyperfunctioning nodule. So this autonomous nodule where there is suppression of the rest of the gland. And this is what you see in thyroiditis. Remember I told you thyroiditis with neck pain, low-grade fever, weakness, non-specific symptoms. So those patients, there is reduced uptake. Why? Because those thyroid colloid, the cells, the colloidal cells are destroyed and they cannot they cannot, take up the radioisotope which you are giving him. So because of the abnormal cells in the thyroid follicles, right? So there is reduced uptake in a patient with thyroiditis. That's how you diagnose Graves' disease from thyroiditis. Thyroiditis, most of the times treatment differs. See, most of the patients with thyroiditis, they are not, you can just, if it's just tachycardia and things like that, you can just put them on some beta blocker and they will be okay. Sometimes you have to start carbimazole, but not for long, and they may also need some non-steroidal anti-inflammatory medications for the inflammation of the thyroid gland. Most of the times, even with the need anti-thyroid drugs, it's only for a few weeks, and then you can take them off, right? But you need to continue to follow them up because some of them may become euthyroid, hypothyroid, or hyperthyroid. Okay. Whereas in a Graves' disease, even if they become euthyroid after a few weeks or months, you have to continue anti-thyroid drugs for at least 18 months, right? In a patient with Graves' disease, right? So it makes a difference regarding the management. So our patient was diagnosed as Graves' disease, started on propranolol. The common form is Inderol long-acting Inderol LA, or Ciplar. That will take care of the tachycardia. I think I didn't show you the ECG. This patient also has atrial fibrillation. It's not present in every patient. Most commonly, you have sinus tachycardia, but now patient had atrial fibrillation, and you can see that it's a irregular rhythm, right? Then there is an absence of P wave and a varying RR interval. Okay, right? So once you control the start on the medications within a few weeks, many of them will turn into sinus rhythm. So propranolol patient will need for the first 1 or 2 months, and you also start them on carbimazole, right? You can divide into BID or BD or a TID dosage 2 or 3 times a day, and you will check the thyroid function test every 3 to 4 weeks, and you will titrate the medications. And even after they become euthyroid, you have to continue for at least 18 months. Okay, and later on you can stop it and see. And some of them will remain euthyroid, and rarely some of them may relapse. Okay. If the patient is pregnant, what will you give? You cannot give carbimazole. In those kind of situations, you may give propyl thiouracil. Okay, in a pregnant patient, because you cannot give carbimazole, you have to give propyl thiouracil until they deliver the baby. Right. The patient is very old and they cannot take anti-thyroid drugs. You can who have completed their families, right? Postmenopausal or someone who is above 40 or 50 years or completed their families, you can directly go for radioactive iodine, which is much simpler. You don't have to take a tablet every day. But many of them, they end up hypothyroid and they may need thyroxine replacement after many months or years, right? And rarely, if it's a very big goiter, or where if there's any compression, you may also go for the surgical option, which is thyroidectomy or a subtotal thyroidectomy or a hemithyroidectomy. Okay, so for most of the young patients will be started on carbimazole and continued for 18 months if they're tolerated. One more thing you remember, whenever you're starting carbimazole, please warn the patient that he should get a CBP done, complete blood picture or complete blood count, so that if they develop any neutropenia, you can pick it up on time. And you also tell the patient that if they develop any sore throat, right, they should tell us immediately, because that is one of the manifestations when the patient develops neutropenia, right? The patient develops neutropenia, you have to stop the drug, okay, and look for other treatment options, okay. So that is a very, very rare side effect, but we should tell the patient and document in your note that you explained them about the very rare risk of neutropenia. Another common side effects like rash and all also, we should try to tell the patient.